Hi everyone, welcome to Entre-Elles. I'm your host, Tombini Kouloufoua, and this podcast is a platform for women of the world to tell their professional success stories. Twice a month, I interview a woman who shares her professional journey and her personal goals. Whether she lives in Abidjan, Accra, London, Paris, or San Francisco, her human experience is universal. Today is March 8th. A very special date since we're marking International Women's Day. It is the perfect occasion for me to celebrate all the amazing women that I've been fortunate to have on this podcast, but also to lift up all the women in my life, my mom, my sister, my friends, and the young girls I am raising. It is a privilege to host these conversations on Entre-Elles, and I hope they inspire you to move forward and structure your own dreams and projects with hope, ambition, and determination. I strongly believe that to fulfill their full potential, women need to be empowered through financial independence, but also through equitable access to healthcare. Therefore, I'm overjoyed to be joined by Lolem Ngong, Chief of Staff at Amref Health Africa in Nairobi, Kenya. Amref Health Africa is the largest African-led health organization on the African continent. Its mission is to increase sustainable health access to communities in Africa. You may have heard of Amref under its original name, the Flying Doctors. I'm very excited to bring you this thoughtful and rich conversation where Lolem and I discussed many topical issues such as STEM education, being an African woman in STEM, the real challenges around public health in Africa, and of course the African response to the COVID-19 pandemic. Happy International Women's Day, and I hope you enjoyed this episode recorded remotely between Nairobi and London. Hi Lolem, welcome to Entre-Elles.
Thank you. Good to be here.
Thank you for accepting my invitation to come on the podcast. As I was saying in the introduction, you are the Chief of Staff at Amref Health Africa in Nairobi, a fantastic organization that does very important work. Before we move to the organization and this topic in particular, let me ask you the traditional question that I ask to all my guests. Where were you born and where did you grow up?
So I was born in Cameroon, specifically in Yaoundé, and spent the first, 12 years in Cameroon, and then moved to Kenya. And Kenya is really where I had most of my sort of formative adolescent life, let me say. And I left Kenya when I was 16 for the US. So I've had, and while in Kenya, so we're between Kenya and Ethiopia. We were very blessed. My sisters and I were quite blessed to have parents who took us along in their diplomatic transfers all over the place. So we happened to live in Ethiopia and then went to boarding school in Kenya. So Kenya is really where I can say I spent most of my formative years.
You studied in the US. You hold a Bachelor of Science in Chemistry and a Master of Public Health from University of Kansas Medical Center. I'm always fascinated by people like you who choose a career path in a sector dedicated to the betterment of society and the greater good. Why did you decide to work in the not-for-profit sector?
Mm-hmm. So actually, I didn't set out to end up in any nonprofit world. My current position is actually the first that's in that's within an NGO or a nonprofit world. The bulk of my career has been really working with government, or working with the U.S. government. Definitely, yes, in the health sector, as you rightly said. I set out actually in the beginning, I was going to become a doctor. And so that's one of the reasons I majored in chemistry, aside from the fact that I do like chemistry. but chemistry was sort of my plan B, in the sense that if I didn't get into medical school, if the doctor thing didn't work out, I could then get a job in chemistry, some doing, I don't know, teaching, working in a lab, being a forensic scientist or food scientist, something in chemistry. And then so that was really my dream, was to be a doctor, following in my mother's footsteps. And somewhere along the line, when I was my last year of university, actually last year of university, sort of, well, between my third and last year of university, I sort of lost interest in medical school, which is an odd thing to say, because every African child is given the two options: a doctor or a lawyer, oh, maybe three, an engineer. And here I was losing interest in becoming a doctor. And I wouldn't say so much that I lost interest in becoming a doctor. I just thought the field that would be most interesting to me if I were a doctor would be emergency medicine. But I also knew that, that had a high rate of burnout and so on and so forth. And I just didn't know that would be the right path to take. And so in my time of panic, because, this is what I had planned for, my aunt said, well, have you ever considered public health? I knew the concept of public health, but I've never really spent time trying to understand what public health is, what it means, how is it different from, a medical career, and so on. And so, I mean, she just kind of threw that out there. And I remember it was probably like in February, I was graduating in May. And so I started looking for schools that were accepting late applications. Of course, I wanted a fantastic program. And I was just lucky enough that the University of Kansas Medical Center, I think I was like 2 weeks away from their deadline. So I applied to them. I'd been considering them for medical school. So I applied to them and got into the program. And that's how I got into public health.
Two questions there. First of all, can you tell our audience what public health is?
Tabani, I'm very biased now, right? Because I love public health to bits. So it will be a very biased response. Public health is everything you need in your life. It's really every aspect that concerns the health of the public. So it's a population view of health. So, for example, when maybe I'll use a very relevant example in our time when we talk about the COVID pandemic, the interventions that are developed, that are popularized or socialized to respond to COVID, those are public health interventions because they look at the entire population. As opposed to medicine, medicine is, it's individual focus. You as an individual go to see your doctor. In public health, we look at the entire population. We look at everything from disease outbreaks. We look at health policy. We look at health financing. We look at health systems. We look at the entire structure of healthcare, and not just the individual healthcare or the individual health of a person. So I would summarize public health in that way.
You studied chemistry, which falls under STEM. And obviously, you know that there are countless conversations and a lot of focus today on addressing the gender disparity in that sector, in getting more girls into STEM, getting more women in these careers. So what's been your experience as a girl in STEM and as a woman in STEM? And do you see what's not working, what needs to be addressed to get more women into these type of careers?
Yeah, no, absolutely. And I would even add to that challenge as an African woman in STEM, right? So there's just the first challenge of being a woman, and then you add the African to it, and it's a whole new challenge. So let me first talk about maybe like the pipeline to this. We're not the immediate traditional profile of who should be in STEM, right? We don't have those images. At least when I was in university and grad school, we didn't have those images. I mean, all of my professors in both chemistry and biology were men throughout college, throughout university. I never had a female professor. I mean, and so I really admire now this really, really strong push to get more women in STEM, to really bring about equity in STEM. But it requires even starting from who are we training to teach STEM, this, STEM courses of chemistry, biology, math, physics, etc. Who are we training as future professors in these areas? Are we affording women those opportunities to be professors, to do research, etc. in these areas? So there's that challenge that needs to be addressed. And that's changing, but I think we can certainly do more. Then the second part is, how are we encouraging our girls to get into this area? I think I was lucky enough, and I think most, I would dare say, and I hope I'm politically correct when I say this, I think, it's one of the beauty of being raised on the African continent is that, to an extent, you also don't really see it as a barrier, right? I mean, as I said, you're just told you're going to become a doctor, lawyer, engineer. I mean, you just go out and you do it. So, the barrier in going to school and deciding you're going to do chemistry, physics, whatever, I think is really not there. But when I look at other contexts, there's a bit of that judgment. Now, even though I say in the African context, yes, as a girl, you can sit in a class and study chemistry, and there isn't an issue with that. But when you get into the workforce, the probability that, if an employer were to pick between myself and a man, the guy will probably get the job, right? As a chemistry professor or as a, PI on a research grant. So these are, and I'm talking about my context. This is back in the late 90s, early 2000s. Those are things that I know women now who are really, really doing a lot of work to change this. Now, in the workforce, in the public health workforce, unfortunately, we're still seeing these disparities. While you may have women in occupying a lot of positions within public health, when you look at the leadership within public health, we're not there, right? We can just if you look back at all the leaders of WHO, for example, right? I believe there've just been 2 women. That's unacceptable. If you look at, and then when you go, and I'm not saying that we should necessarily need to be the director general, but even the next layer down, we're typically absent, right? So it's not only giving lip service to STEM in schools, STEM in, mid-career level, but we want to be at the policy level. We want to be able to shape policy around STEM. We want to talk about making these careers accessible. We want to be decision makers within organizations that are, making great strides or are majority in health, in chemistry, and, whatever it is in the sciences. And I think we still have quite a bit of work to do. And then once we get over that hump, then we get into the pay gap, which is a whole other discussion. It's a whole other discussion that will take us, another hour to just unpack.
Yeah.
Yeah.
To your point, what's interesting is also that so many of those health decisions are actually, about women.
Yes.
So, you, so if anything, if only for that reason, you should definitely have women taking part in the decision-making process at those higher levels. Just before we move on to the next topic, I wanted to challenge you on something you said. When you say that you think that if someone has to choose between you and a man, do you think that's something that's more relevant in STEM, or is that just traditional misogyny?
I think no, traditional. I don't think it's really, yeah. And actually, thank you for challenging me on that. It's not a STEM issue. I think it's our, it's a system. It's our culture. It's our society, and these are things that we all have to change. And when I say this, it's not necessarily to say we need to lean on on our fellow men to change and be allies, because sure, we need them as allies, but we also need to engage women folk, because some of us are barriers to other young women coming into our sectors. So we as women too have to ensure that we're mentoring. We have to ensure that we, when we have that seat at the table, that we look around the table and say, why am I the only one out of 25 people around the table? And why don't we have, I'm not necessarily saying we should be 50-50, but there should be a significant representation.
Yeah.
Yeah.
From the US back to the continent, what was that transition like for you as someone who had left, in her teenage years and who was probably very much an American woman at that point?
Yes. To be very honest, it was not that bad of a transition. I say, but I also know that that is not the norm. For one, I never had any doubt that I would return to the African continent. I mean, I just never had any doubt. I remember even, dating a gentleman in university, and now my parents will know my secrets, and so I mean, dating and and it's progressing, and he was actually from Togo, and like he couldn't he just could not understand my obsession with returning. And even when we, when we discussed marriage, I always said, well, at some point in the near future, I will be back on the continent. So what do you think about that? And he never grew up here. I mean, he grew up, he was born, raised in France, and then moved to the US. So he had no idea, and zero connection in the sense that he wasn't like me, who traveled back. He just never did. When he talked about home, he went to France. So in his mind, that just didn't exist. And I said, that's where we draw the line, right? Because I know I will go back. So I say that to say, in my mind, there was never a question, right? So I always knew in planning my career that I wanted to acquire the skills, I wanted to acquire the experience that will help me when I transition to doing public health on this continent. So I made a decision to leave. I mean, I'd made a decision, yes, throughout, but I became very intentional probably in 2008, 2009. I was just very intentional about, looking for opportunities, networking, doing the most I could, just trying to be in this space. So when I had an opportunity to move back, my first country was good old DRC, Kinshasa. And of course, and I was moving from Atlanta, Georgia to Kinshasa. and had never been to Kinshasa. Had, yes, friends from Congo, friends I grew up with from Congo. There were people who went to my church who were from Congo, and there was not a single person who had an encouraging word. So, not a single one. The the question was the question was always why. Like, why? I just thought, well, I mean, what's the worst that can happen? I hate it and I go to Cameroon. I hate it and I come back. I mean, and I will say at that time, I could take the risk. You know, I wasn't married. I mean, it's like I could move. I didn't have a family to think of. At the time. So yeah, so I packed up my bags in 2012 and I moved to Kinshasa. And yeah, and you know, of course, they're the typical stereotypes about Congo, you know, the dark part of the continent. You know, I think the only, you know, rape and I mean anything, all those, you know, all these stereotypes about DRC. And yeah, DRC has its challenges, but I always say my best public health learning ground was DRC. I am very much indebted to DRC for giving me just an experimental ground in the sense that I was just able to think and to be challenged and to, you know, before moving to DRC, I'd worked for the US Centers for Disease Control and Prevention, which is a fabulous learning institution for me. Yes, it's a job, but I learned a lot and really grounded me in public health. DRC really allowed me to just take that to another level, to gain a lot of confidence in public health and to really understand our context, right? And the plan for DRC was supposed to be 2 years. I ended up staying for almost 4. Loved it, loved every bit of it, the good, the bad, the ugly, the chaos. You know, it's a vibrant city. I'm sure a lot of your listeners are familiar with Kinshasa. Extremely vibrant, colorful, etc. Yeah, and then from Congo, I moved to Ethiopia and did a stint in Ghana and moved. Then I thought to myself, well, you know, maybe I should move back to the West. And there's a fabulous opportunity in Geneva with Gavi, the Vaccine Alliance. So I took on the opportunity, and both for family reasons and personal reasons, I found myself back on the continent, and this time in Kenya. So I don't know. There's some juju on the continent that just keeps pulling me back in. Like it just can't. I don't know. There's something that keeps bringing me back. Yeah.
Oh, amazing. Let's move to what you do now. So you are the chief of staff of Amref Health Africa. First, can you tell us about Amref and what the organization does? I'm sure many people have heard of the organization at some point under the name Flying Doctors, but you'll probably have a more precise description of what it does today.
Sure. So Amref we are the largest international non-governmental organization that is headquartered on the African continent and led from the African continent. We're extremely proud of that. And we were founded in 1957. Our history definitely, as you said, is in Flying Doctors. And when we started in 1957, we're really just trying to figure out a way to get basic health services to underserved communities. And a lot of these communities were really, really far out. And this was it. We started in Kenya. And so these were really far out. And so, you know, if you were to get services there, might take days and days by road. So we started Flying Doctors, which basically delivered services by air. So we just started with a few jets, which that will take whatever commodities, medicine, doctors to serve communities. And over time, we've grown. I call us sort of a one-stop public health shop. So we've grown into an NGO, and then we have 3 subsidiaries. The Amref Group, which includes, like I said, the NGO and subsidiaries, were based in now about, my math is going to be off, we're now based in 10 African countries. But we partner and implement programs across all of sub-Saharan Africa, so about 35 countries. We do have affiliate offices in Europe and North America, and Europe, UK, and North America. And we have a staff of about 1,500 people. The majority are based at our headquarters here in Nairobi. Our subsidiaries are Flying Doctors. So with Flying Doctors, we do medical evacuations across Africa and Europe. And then we have Amref Health Innovations, and that's really our lab. It's like our digital health lab. We test out innovations, we scale innovations, we come up with mobile applications to really facilitate delivery of health services. And then the third subsidiary is Amref International University, and this is really our health sciences university. And the reason we're sort of structured this way is also to ensure that we're aligned with our strategy, which has 3 pillars: investment in human resources for health. So that's where our health university comes in. Delivery of quality services. So that's Flying Doctors, that's our NGO, that's Amref Health Innovations, and then health financing, which is really helping governments to look at, strategic purchasing. How do you ensure that you manage resources, budgets? How do you ensure that you are really well aligned in terms of financing, with ensuring that you're providing the best level of healthcare for your population, making it affordable, making it accessible. And we firmly believe in supporting universal health coverage, right? Which really looks at equity in health service, affordability, accessibility. We work primarily at the community level, and we also work a whole lot with governments across the continent, so both regional government bodies and national. So in a nutshell, that's who we are. We provide a slew of health services, from maternal and child health, community health system strengthening, lab immunization, TB prevention, HIV, NCDs, non-communicable diseases, neglected tropical diseases. We really implement interventions across the entire scale. That's who Amref is.
Can we talk now about your role? What does the chief of staff do?
Oh, that's probably the most interesting question. I always struggle with how I define what I do, because, for some people, when you say chief of staff, they immediately think chief of staff in the army. And it's not that. Or at the White House. So in a nutshell, my role is one, to constantly connects the dots internally in making sure that we are executing our strategy. Also connecting, and that connecting the dots is not only executing our strategy program implementation wise, but it's also in our relationships with external stakeholders. So our partners, our donors, ministries of health. It's making sure that there's always a sort of consistent theme, if you will, and that I'm able to connect different conversations and really just facilitate the work that others at Amref do. So that's one part of it. The other part of it is really serving, and it's really a part I really enjoy. This is working hand in hand with our group chief executive officer, And in that role is, you're part advisor, you're part sounding board, you're part, you're in the planning. You kind of do the, we kind of look at the architect of the organization. We sort of look at what should we be driving, why should we be driving that, what are the global health trends telling us, why is that applicable to Amref. So that's sort of like being a sounding board, brainstorming, looking at what other entities are doing, looking at the political context, the economic context, sitting and triangulating all that information to inform some of our messaging, to inform some of the direction, to inform what new partnerships we go into. So that's sort of what goes into that bucket. So that's really it. It's strategic execution and advising. That's what I do.
I was going to mention that later in the interview, but you touched on it, so I'd like to mention it now. You said that Amref is very much an African organization. I think it was on the Amref website, where it is described as an organization looking to solve African problems with African solutions and African expertise. I'm quoting here. Why is that important?
I mean, it's important because, we know that successful public health interventions have to be tailored to the context, right? So you need to engage people who live and breathe this context every single day, right? So it's not to say that those who are not in the context are not welcome. As I mentioned, we have 11 offices across Europe and North America, but it's to say the solutions and the strategizing has to be done by the people who will be directly affected by the outcomes, right? So there's a different solution. Let me just give a very basic example. And I apologize. My example again is COVID related. I'm trying to make it very relevant to our current times. So when we look at COVID interventions and we specifically immunization, in general, we know, regardless of what part of the world you're in, it's most effective if you meet people where they live, work, play. So in the US, vaccines are available, in the pharmacy, and there's a CVS or there's a CVS at every corner or a pharmacy at every corner. So it's very easy for people to access vaccines, for example. In our context, I mean, we know that one of the ways to be successful, and we've done this for even childhood immunizations, is, Africans, we live in communities, right? You have whoever your chief is or your elder. We very much believe in that communal structure. So there's some interventions that, I mean, I don't care how nice and beautiful they look. If there's zero buy-in from those community leaders, you go nowhere, right? So when we design those interventions and you co-create with leaders and you explain to them, this vaccine against polio, this is why it's important, this is why it's needed, and you use examples that people can touch and feel, right? So, when you go to the market or when you're going to church service or when it's time for, whatever cultural festival, like whether it's the Yam Festival or whatever, and you plan it around that, or you plan it around our nomadic lifestyle for some parts of the continent, like in Cameroon, if you want to vaccinate, let's say the Fulani tribe, I mean, you sort of have to move with them as they move with the seasons and their cattle, right? So it's only normal that our interventions are designed to ensure that, in the month of January, there's going to be this movement because of this cultural festival. So now we need to ensure that we're doing outreach during that time. Or, if we know that Mondays, it's market day, right? So we're most likely to do all the sensitizing and so on during market day because the majority of the population will be there, or a significant proportion, let me say, of the population will be there. So the reason we're very much wedded to African solutions is that if they make sense for the beneficiary, then most likely there'll be uptake. But if it doesn't make sense for the beneficiary, and if the beneficiary can't recognize themselves in that intervention, and the beneficiary's neighbor is like, well, I don't quite understand, it's something that came, there'll be zero uptake. So yeah, so if we want to have sustainable solutions, it has to be one that makes sense for that community. And so that's why we insist on using local expertise, being African-led, and finding solutions that are generated from here.
So I'm going to quote the UN website, and it says that approximately 1.6 million Africans died of malaria, tuberculosis, and HIV-related illnesses in 2015. These diseases can be prevented or treated with timely access to appropriate and affordable medicine, vaccines, and other health services. There are many conversations happening today around food security and the need for Africans to be self-reliant. Do you feel like we should also be having conversations around health security through the lens of local manufacturing and local supply chains?
Absolutely. And actually, those conversations have been going on under global health security. It's for African governments to really seize this moment and be very intentional on what they want to accomplish under global health security. Because these conversations around global health security started way before this current pandemic. For example, DRC has had several Ebola outbreaks, I think probably 7 or so to date. So there's always been conversations around global health security. How do we manage this? And then, of course, the West Africa Ebola outbreak. And then now we find ourselves in a pandemic. And when we look at global health security, it's the entire we look at the entire spectrum. So you're absolutely right. A huge piece of this is manufacturing, right? And we have seen in this pandemic really the critical importance of local manufacturing when we talk about vaccines, right? So when vaccine distribution started on the continent, for example, the first COVID vaccines that were available was AstraZeneca COVID Shield, which is manufactured in India. But as you know, India had this really explosion of COVID cases and basically shut down and was not exporting vaccines anywhere. So now that handicapped us, right? Because of this reliance on the vaccines coming from somewhere else. So that's just an example of why when we talk about health security, you're right, we have to talk about manufacturing. We also have to talk about our supply chain. So it's not enough to manufacture. It's now we've manufactured, how do we ensure that we have a good supply chain which ensures proper transport of, vaccines, other therapeutics, etc., proper storage. When we talk about storage, it shouldn't be limited to, so the supplies land in Yaoundé and then we only focus in Yaoundé. No, it's, when we talk about far-flung places in, for example, Cameroon, what type of a storage capacity do those areas have, right? So it's looking at storage. It's also looking at, do we have the adequate number of health workers, and not just numbers, but, qualified, well-compensated health workers to carry out the duties, when for whatever, whether it's for responding, whether it's for vaccinating people, whether it's for sensitizing the community. Do we have enough community health workers? Are we paying them adequately to make sure that communities know, on Tuesday and Wednesday, we will be carrying out, even if it's just short lessons or tidbits on malaria prevention, for example, or we will be doing, HIV testing, or bring your child for a wellness check. I mean, you need community health workers to be able to sensitize the community so the community also knows where to access health services and what health services they need to demand. So all of that is part of health security. As African countries, if we don't really take advantage of the now to look at everything from our health structure to health financing to health policy, even looking at our global health security framework, if we don't take advantage of doing that now, then we would have missed a whole moment, and there's no telling when the next one will come about.
I know that you've done quite a bit of work on AIDS. When I prepared for this interview, I came across so many information, so many things that I had never heard about. And one of those things was Pepfar. Can you tell the audience what Pepfar is?
Sure. Pepfar stands for the U.S. President's Emergency Plan for AIDS Relief. And Pepfar came about under the administration of President George Bush Jr. It was when HIV/AIDS was basically ravaging the entire world. We had seen significant improvements in the U.S., but we hadn't seen similar gains in the rest of the world. So this became, and it still is, I believe, yes, I think it still is, the largest disease-specific humanitarian assistance that the world has ever known. And so when it started, it was really very much emergency relief. So it was just very much focused on what are those interventions we can get to all these countries around the world to help reduce the occurrence of HIV. And then for those who have HIV, ensure that there's treatment available for them. And not only treatment, but also that they have the entire surrounding package of services. So that's nutrition, making sure that those who develop other opportunistic diseases, for example, pneumonia, that those interventions are available. So a big part of Pepfar is, there's a part that's very much focused on testing and prevention. So that's really, the prevention, trying to reduce the occurrence of disease. And then another part of Pepfar is focused on, now when people get infected, what's the intervention? So making sure that they get the treatment that they need, making sure we can manage their viral load, right? So that they don't progress into AIDS. And then also making sure that we manage opportunistic infections. So Pepfar is housed within the U.S. State Department. It really has footprint all over the world. I believe Pepfar funds probably 3/4 of HIV/AIDS interventions in African countries. And it also looks at not only the prevention and treatment part, it also invests a little bit in health systems, specifically in lab health systems, right? So Pepfar has really been credited with some of our lab networks that we have on the continent. And you'll even see when COVID was, still in the outbreak phase, we really relied on some of those lab network and services that existed for HIV, and quite a number of those were funded out of Pepfar. So each country has a designated budget, which comes from the US Congress. And then they work with implementing partners, work very closely with governments of the specific countries to ensure that whatever the interventions are, they're effective. And each package of course, is very based on a country's priority. But it's a fantastic program. A lot of the successes that we see on this continent when it comes to HIV/AIDS honestly can be credited to Pepfar. Of course, other entities like the Global Fund came later on, but you can't talk about this continent's history of HIV/AIDS without mentioning Pepfar. It's just impossible to do so.
That's really, really fascinating. And what's also interesting is that this initiative was enabled by bipartisan support. And for those who know what the current political landscape is in the US, where bipartisanship seems like a very distant memory sometimes, it's quite amazing, and to hear the strong impact that it's had on reducing the impact of the disease, and it's quite fascinating. Is there an end date to PEPFAR?
That's a very good question. Ideally, there should be an end date. I mean, this program has invested, I think it's upwards of $90 billion since 2003. I mean, that is a massive chunk of money, right? And like you said, it's very much enjoyed bipartisan support. I don't think there's been any administration that has come in that has changed significantly any parameters for PEPFAR. Ideally, there should be an end date. So what has started happening is, at some point, countries are seeing, there's some countries already, and that are already seeing a reduction in PEPFAR funding. One, because, the prevalence, their HIV prevalence is, reduced. So it's no longer, the emergency phase of PEPFAR, we went over that probably 10 years ago, right? And so at this stage, it's really looking at countries where, they have reduced prevalence. So now the prevalence might be in, different pockets. So you might have a high prevalence in, let's say, mining communities, or at the border, or, in sex workers. You might have a higher prevalence there. But in the general population, you might not have a really high prevalence. This is the case in, for example, Ethiopia. I think Ethiopia's country prevalence is like 1.3%, which is very low. But then when you go into pockets, you might see maybe 4 or 5%, which compared to other countries, that's still relatively low, but nonetheless, it's concerning. So the idea is, as prevalence reduces, really ideally what should happen is that the governments of those countries should be taking on provision of those services, because logically, you don't need as much funding to sustain the program anymore, because already now you should have, countries or governments should have certain systems in place. There are structures in place that are already paid for. You already have a workforce. So now it's the country really taking it over. So in the projections, there should be a point where you see this gradual reduction of PEPFAR funding and an increase in domestic funding. That is, if all things being equal, if that actually happened, then we can speak of an actual end date. So we could smell that end date, but it's just not the case because of other challenges, right? So ranging from governments just not being ready, mostly financial. So, not having adequate budget to even sustain, not being able to co-finance, certain interventions. So I'm pessimistic about an end date, and I'm usually an optimistic person, but I'm pessimistic about an end date for PEPFAR. We've seen we've seen in some countries, and I can't name them, where PEPFAR funding has decreased, and then all of a sudden it's like, well, we're reversing gains. So now we have to put in more money for them to catch up and make sure that countries are on a successful trajectory. But I do feel that it's important for there to be, I don't know if I can say, sustained pressure on our governments to really prioritize spending on health. We have to prioritize the health budget. We have to look at universal health coverage. And when we talk about prioritizing the health budget, prioritizing that health budget with an income that comes from domestic resources, right? We shouldn't be still so dependent on external donors to fund our health. I mean, it's the most ridiculous thing, but that's our reality. And as long as we're dependent on external funding for the majority of our health budget, there'll be no end date for programs like Pepfar or Global Fund unless they wake up one morning and say, you know what, we're not funding anymore, which I don't think they will, because of course there are also other geopolitics that come into play. There are also, country interests, all of that. So I don't think, anyone will wake up in the morning and say no more funding is available.
All right, now let's move to the pandemic and to the COVID-19 crisis. So we have been collectively in a global pandemic since 2020. In June 2021, the World Health Organization set a target for all countries to vaccinate 10% of their populations by the end of September 2021. 56 countries were effectively excluded from the global vaccine marketplace and could not reach this target, and most of them are in Africa. The conversation around the pandemic has been dominated by discussions around vaccine equity for a while now. Can you briefly explain why most African countries missed that target and what the blockers are?
One of the biggest and probably one of the reasons that has been really dominating the airwaves is that, when the vaccines were being manufactured, even before there was emergency approval for the use of the vaccines, a lot of well-to-do countries, a lot of the wealthy countries of the world reserved their spot, right? And so countries not only reserved a certain amount and paid for a certain amount of vaccines, but they not only paid for the amount they need, some of them reserved way more than they need, right? So there's some countries that reserved and paid for probably 4 times the amount they needed. And so what that means is, if you have 7 countries that have already reserved, upwards of, so if I just do a rough calculation, total of, 1 billion vaccines during manufacturing, of those 7 countries, none are African countries. And so if 1 billion or more of the vaccines are already reserved and gone, African countries have nothing. So that's one of the reasons why we missed the target, why we couldn't be included in that target, or why we couldn't be seen to achieve that target. It's just the vaccines were not available. Even if we wanted to purchase them, they weren't available. And then, and then also, even with COVAX, which, has really done its best to ensure that vaccines are available for low middle income and low income countries. All COVAX can do is depend on manufacturers to get the vaccines. So even if COVAX has the money to procure the vaccines, they can't procure vaccines that don't exist. And those vaccines don't exist because all these other countries have ordered the vaccines.
I think a lot of people won't know what COVAX is, actually.
In simplest terms, COVAX is basically an agreement between, so it's led by Gavi. Gavi is the Global Vaccine Alliance. It's led by Gavi, and it's in partnership with WHO, with UNICEF, and I'm forgetting one more entity that's part of COVAX. I think CEPI. And so the idea is that through this facility, through this agreement, it's an agreement that focuses specifically on provision of COVID vaccines across the globe. And so the whole impetus of it is to ensure that there's equitable distribution of vaccines. And so COVAX raises money, buys the vaccines, and distributes the vaccines to all these countries. So as you can see, COVAX has to rely on, one, the goodwill of different countries to donate to the facility. And then it also relies on manufacturers to ensure that the vaccines are available. And then it also relies on supply chain to ensure that distribution of vaccine is actually possible. The obstacle then becomes vaccines not being available to even purchase from manufacturers. So it puts African countries in a disadvantaged position because countries themselves can't buy. They're not available. They can't get it through COVAX because COVAX can't get access to the vaccines because there are no vaccines either. And so, and when you even look at, if you were to compare the type of vaccines on each continent, you'll see the African continent ended up having almost every vaccine imaginable, right? So we got Sputnik, Sinopharm, Covishield, AstraZeneca, Pfizer, Moderna, etc. Because at a certain point, you just had to scramble. Countries just had to scramble for whatever they could get to vaccinate their populations. So while some countries were talking about, we now have, at the start of vaccination, last year, March, when countries talked about, we have 3 million vaccines available, African countries, we were still talking about 100,000 doses came into a country, which is just ridiculous, right? So you see why we can't meet our targets. The other reason we weren't in a good position to meet our targets is just also that, we also, while we did plan, most African countries did plan, we did the sort of logistical planning in terms of, how many vaccines do we need, who's eligible, and so on and so forth. Then when vaccines arrived, within each country, within the country, we hadn't really thought about, rural areas, how many vaccines do they get? What's based on their population, do we send X rural area 10,000 vaccines and send another one 15,000, just depending on their population, right? So some of those things really didn't help us. And then we also didn't do enough. And I think this one was a problem across the world. We just didn't do enough. We weren't as aggressive with sensitizing communities. I think we sort of took for granted, particularly on this continent, Africans are not, we're not anti-vaxxers by nature, right? I don't know, I don't have a single friend or family member who does not know what a yellow vaccination card is. We all know it. We all have some of our vaccine marks to show it. So we vaccinate. We just know when you have your baby, you have to make sure your baby gets all these vaccinations. So we're not anti-vaxxers. But one thing we forgot is that this pandemic has also been, we've also had this epidemic of false information, right? And I think we just kind of took for granted that, but people believe in vaccines, so how hard can it be? Well, it's quite hard when you're fighting a really big false information machine. So we weren't as aggressive in fighting that, so that people felt very well informed. People knew exactly where to get the vaccines, and people understood why they should get vaccinated. So I think there was a delay in that. And so we saw in the beginning a very slow uptake of vaccines. And then now, as people are getting more educated, people understand, you see when vaccines come in, the lines are long. There's a long queue because people are want to get vaccinated. People are very conscious about, after 6 months, I need to get my booster. But that just took a while for us to get there.
So yesterday, February 18, the World Health Organization said that 6 African countries, Egypt, Kenya, Nigeria, Senegal, South Africa, and Tunisia, would be the first on the continent to receive the technology needed to produce mRNA vaccines. Is that something to hugely celebrate, or is that something that's coming super late? How do you feel about the announcement?
No, I think this is really, really big news. I mean, it's really big news. Amref, we had put out we have a vaccine equity campaign that's ongoing. And as part of the campaign has like 5 actions. And one of the actions is, sharing technology. So when we talk about manufacturing on our continent, we know for sure we can't just wake up in the morning and start manufacturing vaccines, right? There's a whole preparation phase. There's a whole setting up structures and so on before we can actually manufacture vaccines and other therapeutics from scratch. On our continent, 99% of the vaccines on our continent are imported. Only 1% are manufactured on this continent. So this was big news because we had been pushing, and Amref and other people as well, had really been pushing for, at the very least, share the technology. Because if you share the technology, then we can produce the vaccines, right? As we set up the structures needed to manufacture. So this was just amazing news. It's important news for all of us. It really facilitates so many discussions. It also really helps us see the possibilities for research and development on the continent. Well, elevating research and development, because we do quite a bit of research and development. It's just not popularized, but it really elevates research and development. It gives young researchers an opportunity, to research different therapeutics, to be able to actually manufacture those therapeutics. So it's even beyond COVID. It's beyond sharing this mRNA technology for COVID. Beyond that, it's really looking at everything else, all the other possibilities that come with this announcement. So it's certainly to be celebrated. I know that we will take advantage of this. The Africa Centers for Disease Control and Prevention had already set up last year a partnership for African vaccine manufacturing. And they had looked, I think their timeline to get there was like 2035, but I may have to look that up and correct myself, but to get to 100% manufacturing. But, this really is a huge boost to that partnership. For me, it was amazing news. It was probably the best piece of news we've received this year, not just for COVID, but also just for healthcare across the continent.
So you've mentioned universal health coverage twice in this interview. Can you tell us why that is so important, and what is the work that is being done behind the scene on that?
To put it simply, universal health coverage is important in order to ensure that we have access to quality health services. That's really what it is. So that wherever you are, in any corner of this continent, you can access health services. If you have from the most minor needs, if you have a headache and you need to access quality medicines, you have that. If you are a mother in labor, you have the trust that when you go to X health facility, you will get the best care. There'll be fantastic equipment. You will have a trained person attending to you, etc. And at the end of it all, it is affordable. Good healthcare should not be affordable for only the middle class, upper class, and uber wealthy people. good healthcare should be affordable to everybody who is living, basically. So that's really the premise of universal healthcare, is that, or universal health coverage, is that healthcare is affordable, it's accessible, it's equitable. That's really it. And it's important in our context because you see an increase, there's a very huge increase in out-of-pocket costs, right? I have seen anecdotally, somebody falls sick, somebody calls you, oh, can you donate this much? We're trying to gather money together to send the person to India or to send the person to, I don't know where. Or we even see our own politicians, when they get really sick, they fly out to Switzerland, they fly out to the UK or whatever. Why can't they get that same healthcare here? I mean, if I were a politician, that's the question I would be asking. Why am I on a plane to England? Why can't I get that healthcare in my country? Right? So the conversations that have been going on the continent, a huge part of it is this conversation on health financing. Because without us figuring out health financing, we can't get to universal health coverage, right? Because the health financing piece is what enables us to have affordable healthcare. So this can be in terms of governments substituting for healthcare, like Kenya has the NHIF. But it's like those policies in place, whether it's employers paying for a portion of healthcare, whether it's, through taxation, depending on the country. So a huge part of those conversations are around health financing. So just beginning of last year, we pulled together 11 African experts, and the task that they were given was to basically review the status of universal health coverage, UHC, across the entire continent, and to see, how far countries were in reaching their goals. And so the commission is called the AHEC Commission, and it's the Africa Health. It's actually the Africa Health Agenda International Conference, which is held every 2 years. So the next one is 2023 in March. But as part of the 2021 conference, we pulled together this commission. So the AHEC Commission got together, looked across the board at a progress towards universal health coverage. And one thing the report highlights is probably about 80% to 85% of African countries do have a very good policy on UHC. Where we struggle is the implementation of it, right? So there's a huge call to governments to really push, the policies around access to health, to look at health financing, and even to look at integration of health services. So it even goes down to, when you go to a clinic, you have, an immunization clinic, then you have a well baby clinic. Then you have, a maternal and child health clinic, which doesn't make sense. So it's looking at integration of health services. So you are providing the most optimal package of primary healthcare services in order to also achieve universal health coverage. So those are some of the conversations that are happening now is, looking at the structure of our health system. So this is where integration of primary healthcare services comes in, looking at health financing, and then also looking at our health policies.
Let's end on a segment that's called React to a Quote on the podcast. So I will give you a quote and I would like you to react to it and tell me, how you feel about it. Do you agree, disagree, why? Here's the quote: "Vaccine equity is not charity." And that's a quote by Dr. Tedros, the WHO Director General.
Vaccine equity is indeed not charity. Vaccine equity is a very basic human right. It's the right to access a service which should be available, right? So it's not begging for something. That's one. Two, vaccine equity ensures global safety, right? One of the phrases that has been really popularized is, nobody's safe until we're all safe. It's very true. We live in an extremely global world. If we didn't live in this world that is so connected, we wouldn't be talking about a COVID pandemic. We travel, we interact. You can't do anything without interacting. So until we're all safe, nobody's safe. So, the US, the UK, all these other countries can boast of high vaccination achievement, but it really means nothing until the rest of the world can also talk about those similar achievements. Why? Because you can achieve, but until the rest of us are at that level or almost there, the risk of disease transmission, the risk of mutations is still there, right? We've seen so many variants of COVID. So we're not safe. And that's why vaccine equity is not charity, because in fact, it's critical. It's critical for all of us to have access to vaccines, to the COVID vaccine. If we don't have access to the COVID vaccine, we can't reach our vaccination targets. And so nobody is safe. So it is really, for me, it is really it is a responsibility of us all. It's not just the responsibility of one country or one part of the world. It's a non-negotiable aspect of bringing COVID under control. And so that's, I fully support that statement. Indeed, it's not charity.
This was such a great conversation. Thank you so much to Lolem for this very open exchange and for sharing her deep knowledge of the African health landscape with us. I hope you enjoyed this episode of Entre-Elles, and if you did, please go to Apple Podcasts, Spotify, or your favorite podcast app and subscribe to be notified of new episodes. While you're there, please leave us a rating and a review to support us. You can follow us on social media at Entre-Elles Podcast. Thank you for listening, and see you in 2 weeks for a new episode in French and in a month for a new episode in English.